On that optimistic note, I'm delighted. I particularly enjoyed that tortoise that, in spite of all the foreboding powers of culture, was inches away from the finish line. So I'll maintain that optimism. So it's my great pleasure to invite Dr. Johan Lennerz, who's the medical director for the Center of Integrated Diagnostics and Associate Chief of Pathology at Mass General, to give his talk.
Thank you very much. I want to start trying to... I want to start by telling you a brief story, because what I'm about to tell you, which might turn out to be a positive message, actually starts with a negative one. So we all have done postdocs or published papers, and at some point, maybe, at least my PI asked me, so what? What happens? You know, all these promises. We say, oh, if you implement this, we may optimize cancer diagnostics. Or if other labs would confirm this approach, we could totally change the world. The problem is, at some point, we asked ourselves, who are those labs? Who are these people, other than citing papers, to really do an assessment whether this would really work in clinical practice? Now, as a pathologist, we love talking about valleys of death. We like talking about death, but here are two valleys. And the Center for Integrated Diagnostics, as we conceptualized it in 2013, is tackling specifically the second. This is not translational medicine. We're talking about the final step to actually bringing it to bedside, just for concept. The most critical and most important, as always, element in what I'm about to tell you are the people. This is showing you the structure of what the Center for Integrated Diagnostics, or CID, looks like right now. And I'm using this already as a thank you slide to the team, because it wouldn't be possible without it. As a concept, you see there's basically 3-4 main buckets. On the left side, in yellow, are research laboratories. In this case, portrayed Dr. John Ifredi, my mentor. He still has a research lab despite being a chief, and they develop new tests. That's the translational part. And if they're ready, we will take them on. You see in blue, the technical section of the lab. This is a high complexity, CLIA approved or CLIA certified New York State approved laboratory. We have FDA and non-FDA approved tests. We currently have 49 laboratory developed tests. We do a lot of data integration for AI models live for 5 years, etc. You see in green, our faculty. Those are typically MD or MD PhDs or PhDs who have a molecular genetic pathology background and are working on this and have a dedicated time that is set aside to do test development and integration. And then on the right, in orange, which we try to keep balanced with the number of faculty members, is bioinformatics. This is the current setup. You see the reporting structure. This is somewhere situated within pathology, but very close to the cancer center, to other disciplines. And what's not shown here is a direct tie to the payer operations, and I get to that in a second. To show you what it looks like, we have developed a plot. This I took last night as a screenshot. This is what we refer to as the Earth section of the lab. You can see some tests we bring on, so this is test volume over time. You see that this is roughly going by month. That's the iterations. We have about 14,000 tests a year, and we're not operating to scale. You see the COVID dip, which is, I think, an internal built-in control from now on for future reference. In case you don't see that, there must be some tinkering with the data. But what I wanted to show with this case is we bring on things and we take them down. Both are completely different skills, but you have to have a baseline of tests that is run continuously and sustainably to support your operation. Keep in mind, this is not research, this is clinical volumes, and we bring on tests, we go through the full cycle of getting payer policies adopted, et cetera, to bring them on and take them down to learn something from it and see whether it makes sense. So overall, this is basically the two slides, the team and then an agile infrastructure to bring on things moving them forward and backward is very important. Now, the two things that I thought I can share from our team's experience that may help in the discussion today is the following. On the left side is our current idea of what diagnostic test quality is. And I wanted to share it because we talk about a lot of different things. The actual test, let's say a CT scan or a PCR, we consider the diagnostic test. That's in that Russian doll model on the left in the center. It requires a procedure to be executed. If we use the example of COVID, a nasopharyngeal swab or a mouth swab, that's the procedure. It could be different protocols running on the same test. And to offer that to patients, we have a service layer, and all of that lives in a healthcare ecosystem. All of those things have to be aligned to make it a good diagnostic quality. Now, if you go to the right part of the slide, if you take this Russian doll and you want to integrate it, you have to do a tech assessment of whatever that is. It could be just a service change, or it could be a diagnostic test change. And then we came up with this dual layer. One is you have to check for financial sustainability structure through payers, and then do the whole-on integration part. We can talk about this. Ultimately, to hand the test to a destination lab to free up your own team to do more innovative stuff. Hence, not built for scale, but for integrating new things. What does that look like? We're here at talking about cancer care, and on top is an idealized and in real-world workup. At the current stage, and I'll show you what the implementation looks like, for some patients that qualify certain eligibility criteria given, a biopsy followed by a frozen section followed by immediate extraction, same day NGS, will result in a report that is coupled to the specialty pharmacy dispensing mechanism and cost coverage, for example, for low-income populations, to dispense the drug next day. That was a long-term dream of mine, and I'm very happy that everyone believed in it and it works. You see in the bottom right a comparison. Red is this so-called specialty pharmacy workflow in red. You see the median time from biopsy or ordering actually to dispensing of the drug in an EGFR patient population is roughly speaking 5 days. All the way on the bottom, you see 5 patients who actually got it same day. And in comparison, the non-rapid EGFR mutant control cohort, which is still getting, I think, excellent service and fast turnaround time NGS, the median time is roughly speaking 40 days. By that time, as shown in the top row, most of the patients in the rapid program already achieved their first response. Now that is the promise, at least in what we tried and hopefully continue to manifest of integrated diagnostics, where you select a certain workflow and you put everything in place for that specific use case to work as seamlessly as possible to achieve your intended outcome. Now, as a workflow comparison, none of this would work if you eliminate the traditional siloed workflow. So if you compare the top versus the bottom part, there is a need for traditional CT scan and CT-guided biopsies. There is a need for routine histology and molecular diagnostics. So akin to the Earth section, where you have a baseline that keeps each service running, in our experience, integrated diagnostics works best if you have the siloed infrastructure, but align all the components, including the administrative components, in a way that they work best harmonized for a specific workflow. So I want to propose an integrated diagnostic definition that follows what we heard earlier. It is not just the integration of multiple modalities, but it is a functional alignment of meaningful diagnostic and the relevant administrative components for a specific so-called patient journey. So currently we have several initiatives, and I want to throw out one which is depicted in blue here. That is, if you concatenate these Russian dolls to one another, what's shown here is a diagnostic CT scan that would predict the downstream molecular finding after biopsy, where you would use the molecular findings to continuously update the online learning radiology model. these models cannot function in clinical practice unless you have a continuous feedback loop from the downstream future ground truth. I don't know why there's a screenshot over it. Can you just check in the slide deck? Because that wasn't in my final deck, but I can definitely argue what the summary slide should show. So the key elements here are, number one, we value the people, as I hope I showed. We look for tinkerers and people that can actually communicate and collaborate, rather than just looking for a one tech-savvy, isolated skill set. Second part is we look for sustainable solutions rather than quick wins. The third is we need financial sustainability through payer operations rather than solely focusing on one specific funding realm. Yes, of course, we need third-party funding, we need institutional support, but eventually we want to move towards payer operations that actually work. And then lastly, as you see, patient centricity over scholarly activity, probably the most important. So here you see if I was able to recap my summary without knowing it, but with that, thank you so much, and I'm looking forward to the discussion.